Hello and good morning everyone, and welcome to today's webinar. My name is Jeff, I'm the Director here at Insight. It's my great pleasure to welcome you here today. Before we continue, I'd like to acknowledge the traditional owners of the land of which we gather today and pay respects to elders past, present and emerging, and extend that respect to any Aboriginal and Torres Strait Islanders joining us in the room or in webinar land today. The new focus for lots of us is the topic of opioids, and both in terms of illicit and prescribed or pharmaceutical opioids is a growing issue both in Australia and across the world, and we've dedicated this particular seminar series to opioids in respect of that it's increasing kind of concern for workers and families and individuals alike. And so our internal clinical educator Dan Phillips, a psychologist, has spent some work researching this, and it's my great pleasure to introduce Dan today to talk about opioids, scaling up the analgesic ladder wrong by wrong. Welcome to the stage, Dan.
I'd also like to acknowledge the traditional custodians and pay respect to elders, and I've got a picture of Jack Charles there to start off with, and Jack is someone who has lived experience with opioid use, and he has spoken openly about how he has made his own changes in drawing from other factors besides just biological factors, looking at cultural factors. And today, with the view on opioids, we'll be looking more at what's happened as far as culturally and socially, and I think also an emphasis on the psychological reasons behind it too. The title, Scaling Up the Analgesic Ladder Wrong by Wrong, I got that from the World Health Organisation with their analgesic ladder that they had, and I got the other bit from Mae West. Just like to show you a picture of my step ladder. I never knew my real ladder. So I've got an hour of ladder jokes for you. No, I haven't. So what I'm going to talk about today is what's happened, how did we get here, and what can be done. So the concerns, I've gone through that beforehand with the people in the room, that there are quite a few things that can go wrong if people are on opioids long term. And the main one is the top bullet point there at the end, the overdoses, and also the bottom bullet point there, the risk of addiction that can happen. So looking at a world view, I must commend whoever put that map together. They did a very good job. They did leave out New Zealand and Tasmania, but otherwise they did a good job.
I thought that was wide.
Start off with a review by NDARC, which looked at the world picture, the global prevalence of non-medical use of opioids and dependence. It's a recent one from 2017. So it was quite extensive in the amount of data that was collected, and like with so much in drug and alcohol, a large part came from the USA. What they found was that there has been quite a significant increase. So that increase in deaths from opioids, increase in has been happening in the US, but happening globally as well. And came up with a number down the bottom there for 2015 of 122,100 deaths from opioids, which is huge. It's you think of every one of those deaths as a personal tragedy and the impact on all those different other people's families and friends. In Australia, there's some good news that there's quite intensive interventions available with opioid substitution therapy and needle syringe program, so the death rate is lower compared to other countries which don't have those treatments, those interventions. I'm going to focus on the US a fair bit today, so I hope people don't mind, but it is quite an extreme what's happened there, and I think it has also been leading the way for what's happening here too. So this is a slide that came from a US Republican senator, and so with 5% of the population, they're using 80% of the world's opioids, which I heard a while back that the US has 5% of the world's population and uses 50% of the world's resources, so it's worse than what they normally do with overconsumption. So they've taken steps. So the opioids, the crisis next door, and you can see that the president is dealing with that as he knows best. and his first lady is the one who seems to have the details there. So she talks about the numbers of people being impacted, and they've got a figure of 175 Americans overdosing every day. So that averages out to the time the seminar takes, there'll be like 7 Americans who would have died. So it's huge numbers that are happening there. So what they've done is they've controlled the supply, so they've made it harder to get prescription opioids. James Martin, a researcher from Swinburne, who's done a lot of work on the dark net, wrote about how this has meant there's been more people going for illicit opioids, and so a lot more happening on the dark net. And when people go for something illegal, they tend to go for the more potent form. So that has meant the more dangerous types of opioids like fentanyl have become more common. Dr. Martin also has boots too. You may be aware of those. I spoke of the iron law of prohibition. So what happened in the US is that when alcohol was prohibited, people were drinking more of the stronger forms of alcohol, whiskey and gin, rather than beer and wine. And can see similarities with opium being banned and increase in heroin, and what's happening here in Australia now with amphetamines. We've got the high purity crystal methamphetamine, and with cannabis, who smokes leaf now? It seems to be all heads that smoked. Joshua Lee from the New York School of Medicine spoke about this too, that there was the huge amount of opioids being prescribed in the 90s and the 2000s, but now there's an increase in heroin being used, but that heroin is contaminated with illegally manufactured fentanyl. And so the DEA there has estimates that 4 out of 5 new heroin users had previously been using prescription drugs. So we've got the analogy of gateway drug with what was described before with cannabis, but now I can apply that with what's happening with the prescription opioids, leading to illicit heroin, illicit fentanyl. The United States of fentanyl. So the manufacturing of fentanyl has increased greatly. So the death rate from fentanyl has increased by 5 times in the last 3 years, to the point now where drug overdose is the leading cause of death for Americans under 50. So it's such a huge factor in US life now. In the US, about 2 million people might be abusing or dependent on prescription opioids. 2016, about 60,000 Americans died. Fentanyl involved in a third of those. The mortality rate from prescription opioids is greater than that from heroin and cocaine combined. But that last one really shocked me, that an addicted baby is born every half hour, and in Huntington, West Virginia, hardly what you'd think of as a drug capital of the world, 10% of newborns are dependent on opioids. So public displays like this have happened in the US, just with every one of those rest in peace markers representing someone who's died from opioids. So since 1999, 200,000 Americans have died from opioid overdoses. Canada, their neighbour, has also had big problems. So Canada, O stands for opioid for today. It's the second biggest per capita user of opioids, and similar to the US, increase in fentanyl. So they've introduced programs to help with that with prescribing of naloxone to try and prevent. Australia, bringing back to home, what's happening here? So Australia currently ranks 8th as far as the number of defined doses of prescription opioids per million, which gave me a chance to show off the contents of my trophy cabinet there. It was a tough race, but yeah. Luckily for me, there are only 8 lanes in the pool, so I came away with the ribbon. But in Australia, we've seen similarly that we've had this big increase, and also we've gone from the weaker to the stronger acting opioids. And the conditions it's prescribed for is greatly increased, so it's been prescribed for things that previously opioids wouldn't have been prescribed for. So estimates that there might be 500,000 people on prescription opioids currently who are dependent. I've seen other times it's been written as 750,000. So it's a very significant number. Prescription opioids now account for 4 times as many hospitalisations as heroin. And with opioid overdoses, the prescription opioids account for 70% of those, so it's similar to what's happening in the US and elsewhere in the world. Opium farmer, so an Australian opium farmer there, has a much bigger field. So he'd be supplying the prescription opioids with their opium, and then the other side got an opium farmer from Myanmar where the heroin opium is farmed from. So the Myanmar farmer you can see is multitasking, but she does a smaller farm. With what's going on, the numbers there are really significant. So you can see there's 2.9 million Australians on a prescription opioid compared to 93,000 who inject. So you can see why there's so many more hospitalisations, why so many more overdoses. Over the course of the year, 20% of Australians over 45 will be prescribed at least one opioid. So that's quite a large number. So I had that brought home to me as someone I knew who had a surgery and was prescribed endone, and she was in her 60s and she was out with friends at lunch and she talked about how finished the endone but was still hurting, and then with her half a dozen friends at the table, every one of them had endone. Every one of them was offering to lend her some or give her some. So I think just how much is being prescribed now. This is Australian stats, so you can see the different opioids there, and around 2000 that light blue for oxycodone starts to increase and increase. There's a black line there where the data from private prescription was no longer available, so that decrease that's happened since then may not be accurate. The Pharmaceutical Benefits Scheme. Now, how did that name get up? You know, scheme? So the subsidy for OxyContin started in 2000, so then a lot more being used. The promotion, an ideal analgesic, purportedly having a short half-life and a long duration of action. Rapid analgesic activity, no active metabolites, predictable pharmacokinetics, and fewer side effects than morphine. So that sounds great, so why wouldn't people prescribe that? So with the last household survey, found that there was an increase in age of those using the non-medical use of pharmaceuticals, and those who were using it quite frequently, so quite a large number using it daily or weekly. The people at most risk, remote areas. So it's something we've seen with other drugs too, that it's more of a remote area issue than in the major cities. And we've also seen that social gradient, that the poorer socioeconomic areas have a higher level of use compared to the richer ones, similar to like you see with methamphetamine. Naturally, the people unable to participate in the workforce, people with injuries are more likely to use it. The Aboriginal Torres Strait Islander data may not be that reliable because it's quite a small sample. With chronic non-cancer pain, counts for half of the prescriptions. So it's being prescribed for what opioids weren't being prescribed for before, and also people have been prescribed longer, so longer treatment on opioids than before, even though the evidence doesn't support that. But this general approval in the community, so the approval rate of using pharmaceuticals for non-medical purposes is quite high when you look at that compared to smoking cannabis or tobacco. Dr. Susan Nielsen from Mendark has done a lot of work on opioids, and her research estimates that there could be up to a quarter of people who are being prescribed opioids meet the criteria for dependence. So hence there should be a need for more treatment. The people being prescribed opioids for dependence, a lot of Australians have spoken openly about it. They haven't all been white male celebrities, they're just the ones I could think of. I thought if I put a picture of Matt Cooper in, that might help, because gratuitous nudity always helps with ratings, so I thought I'd stick that one in there too. Coming to Queensland now. MRQ data, so from that 6-year period from 2006 to 2012, there was a doubling, and then recently we had Bill Loveday present here, and he said the recent stats was 200,000 opioid prescriptions in a month now. So it's gone up another 60,000 in the next 6 years. There's been a big increase in fentanyl and a really huge increase in oxycodone over that since 2000. The wastewater monitoring program, what's coming out of there is interesting. With oxycodone, if we look at what's happened in Brisbane and rural Queensland, the most recent ones, the trend is going down, which is good news. But if you look at Tasmania with Hobart, the white one, it just doubled somehow. So oxycodone level in Tasmania and in Canberra are far higher than other parts of the country. Fentanyl, the most recent one, has rural Queensland with the highest level of use in the country. So it's increasing and increasing there. Heroin, not so much an issue for Queensland compared to other states. So Melbourne used to be really out there on its own, but it's come back to be similar to Canberra now. So that's where we are. How did we get here? How did this all happen? So since ancient times, people have known about the opium poppy and the benefits that came from it, but they also have known about the problems with addiction. And I know a bit about ancient times and the milk of the poppy because I've seen every episode of Game of Thrones. So if you want to find out more, I can tell you later. So this new product called morphine came along, and that was available over the counter and people were buying it, and it became a big issue, and it was described at the time as the Great American Fraud. And so there was a huge problem with the number of people who became dependent on that product. So regulations were brought in. The next was heroin. So with making of heroin stronger than morphine, but thought to be far less addictive. But we know different now. So that was marketed as a non-addictive morphine substitute, but then lots of things happened, so regulations are put on that one as well. With the labelling of morphine, the labelling of heroin, you can see down the bottom there, I've blown it up to make it easier to read, the dosage for children. So how much heroin to give your kids. That doesn't happen these days. So in the US, they brought in the Harrison Narcotic Act, which was all about controlling the supply and prohibiting. And that still sets the tone today, where it gets to the point now where half of people going to prison in the US, it's for drug offences. Dilaudid came along, so thought to be 5 times as potent as morphine, but as harmless as water with no habit-forming qualities. But it wasn't. It was also Elvis Presley's favourite medication. So oxycodone, trying to create that non-addictive version of heroin, had this problem with people not breathing when they took it, so they mixed it with ephedrine, and that was not really effective. So then the search to try and create an alternative to morphine, which led us to OxyContin. So mixing with oxycodone with Contin, these different waxes and resins which help to control the release of the medication and prolong its effect. And Purdue, the company who was producing that, had done it previously with morphine sulfate with MS Contin, which was their biggest seller in history. So you can see why they persevered to go with creating OxyContin. Released in 1995, and with the slogan that it might be less likely to cause abuse and addiction. Well, that's very reassuring. And then the marketing team came up with a product to start with and to stay with. So that rings alarm bells as far as opioids go. So doctors were a bit hesitant about prescribing opioids that you might be staying with. So they were told, you're opioid-phobic. They came up with this term. So rather than making a reasonable decision based on the evidence, they were being accused of just being emotional and being anxious about it. The company, Purdue, was bought by 3 brothers, the Sackler brothers in the 50s, were all psychiatrists and who learnt about marketing. And Arthur Sackler and the team there, they helped make Valium into the first $100 million drug. So of all the drugs to make into your first $100 million drug, it was Valium. And so there's the Medical Advertising Hall of Fame. I don't know if you're familiar with that. Do we have an Alcohol and Drug Treatment Hall of Fame? don't think we do, but there's a Medical Advertising Hall of Fame, and the very first time people were inducted into it, Arthur Sackler was there front and centre. So they still have their annual awards and induct people. If you'd like to go, it's only $450 a ticket for a dinner. So if you're not busy next year. So Purdue actually has so much money that they can really influence the sector in large ways. So what they've done with OxyContin was they paid for these seminars in nice sunny locales and invited key opinion leaders to those conferences, and promoted how the drug was much safer than what it really was. And they also provide a whole lot of other educational campaigns for other people to attend. There was a letter printed in a journal which claimed that there was a very low risk of addiction when prescribing these opioids, and that was cited again and again and again in later articles. So people can have a reference, but they might actually have any evidence. So this reference didn't actually have any evidence, it was just an opinion, but it just got cited over and over again to back up the support of prescribing opioids. With the marketing of OxyContin, they actually provided free textbooks to medical schools in which they amended, it's not one way of putting it, a list of weaker opioids and putting oxycodone in there. So lots of doctors were being trained to believe that it was less potent than morphine. With pharmaceutical companies, if they have a product, then they try and push the idea as to what that product's going to be treated for. So whatever that diagnosis gets a lot of publicity. So they provide a lot of money to the American Pain Society with this campaign of pain being the new vital sign, and there was also the US Congress declared it the Decade of Pain Control, and the World Health Organization had a Global Day Against Pain, and Montreal saying access to pain management is a fundamental human right. So all this sounds like it's coming from a good place until you look back with hindsight and see what the drive was behind it. So they would provide free sample packs. So this is something that I'm familiar with heroin dealers giving free samples to new customers. So new customers get it for free initially, and then after they've developed a bit of experience with it, they'll be more than likely to make up for whatever they've got for free with their business later. So the sales of OxyContin increased greatly. So they were able to increase their sales force as a result. These are some of the giveaways they had. A lot of people talked about the CD, get in the swing with OxyContin, but what really shocked me was right there in the middle was the child's cuddly toy. The idea of giving a little baby a cuddly pill to cuddle. You love your opioid from a very young age, and the indoctrination starts early. So New York lawyer Paul Hanley has written about some of the claims from Purdue that patients on a daily dose below 60 milligrams could stop without any withdrawals. Fewer than 1% became addicted. But this was just stuff coming out of the marketing department. There wasn't any evidence to back it up. The FDA, initially when Purdue was released, recognised that there weren't any of these other benefits of, less likely for it to be abused, less likely for overdose. All they could see was that it needed to take the doses, the frequency of dosing was less. That's all they could see. So released in 95, and then the sales just grew and grew and grew. So within a few years, by 2000, sales were over $1 billion. So there's a lot of money then to spend on marketing promotion. And the increase in prescribing for non-cancer related pain, but also for cancer-related pain as well. And so sales went right up, but then it soon became the leading drug of abuse in the US too in another few years. And what was described as Pharmageddon. So Purdue would just say that the people who were abusing were, it wasn't anything to do with the drug, it was just that the people having problems were abusers, And so Mark Sullivan, a psychiatrist at University of Washington, shorten the argument to being basically our product isn't dangerous, it's the people who are dangerous. And so that holds a fair bit of water for a lot of people, because a lot of people still see addiction as a sign of lack of willpower. So seen different surveys that have estimates up to a third of Americans seeing it that way. I get a feeling it would be quite similar here in Australia too. So this idea that it's the person's fault, it's not the drug's fault, is a bit similar, I think, to, you know, the guns don't kill people, it's the people that kill people. There's some evidence that refutes that comes from Australia. So Dr. Frey from Turning Point, he probably won't thank me for picking that photo, but I couldn't go past it. So in Australia, it's been found that 70% of people who've overdosed on pharmaceuticals had just the one doctor. So the frequency of doctor shoppers just wasn't there in the evidence. Susan Nielsen from NDARC has talked about how half the people who've overdosed, there's no history of illicit drug use. And then of the other half where there is a history, a large proportion of that is just people who've had cannabis. So Purdue ended up being fined, and they got a very large fine, and 634 million, but not when you're making over $1 billion a year. So a Republican senator described that as just an excessive license for criminal misconduct. So what's happening with oxycodone in Australia? So the dark blue is the OxyContin. You can see when that was listed on the PBS how much oxycodone prescription sales increased, and with so much of it come from the OxyContin. All the other opioids have sort of plateaued, but the oxycodone is the top one there, the top seller, and increasing and increasing. Injecting OxyContin. So Purdue knew about this issue because they'd had the same thing happen with MS-Contin, and they knew from their original testing before the product was released that it could be done, but they still released the product. What often happens when a company's product comes to the end of its patent, that they change it in a way so they can renew the patent. And so we've had this reformulation of OxyContin, and with the idea that would be an abuse deterrent. Abuse deterrent, is that correct? When most people who are abusing are actually taking it orally anyway. And it's easy to find ways to get around this by just going online. And the new form, the tamper-resistant form, abuse deterrent form, is so much more expensive anyway. Australian paper looked at what happened with tamper-resistant form and saw there hadn't been any effect on overprescribing, overuse or harm from opioids. And that makes sense because so few people are actually injecting compared to taking it orally. Fake OxyContin. So illicit drug makers knew that OxyContin was what was popular, so they've been copying the pill and the colour and the design, but making it with fentanyl. So people think they're getting OxyContin that they're used to and they know what they're doing, but what they've been actually sold is fentanyl. And a famous case is Prince, who died from a fentanyl overdose. And he had his own doctor, and they probably thought that they were getting OxyContin and that they were judging it correctly, but ended up overdosing. Fentanyl, sometimes known as China Girl, hence the clip from the still from the David Bowie song. 50 times stronger than heroin, and you can see the tiny amount there needed for overdose. Initially subsidised in the PBS for extreme cancer pain in '99, and now there's around 1,600 people being prescribed fentanyl every day. A patch can be bought for a few dollars, but they may be sold on for $100. So you can see the red mark as to when it was PBS listed, and then amount of fentanyl greatly increased after that. With fentanyl, it's very hard to know what you're doing, what the concentration is. So with people who are injecting, there's a great risk of overdose, and it's described as Russian roulette. So the people I've known who've overdosed from fentanyl have been experienced opioid injectors, been doing it for ages, and even with all that experience, it was still too hard to judge. There are fentanyl analogues too, so there's all these other types of fentanyl as well, chemical cousins of fentanyl, and in Tom Petty's toxicology report, there were listed not just fentanyl, but a couple of others, along with some other medications too. So there's been quite a few people who've died from fentanyl that we may all know. Prince, Lil Peep, Dolores O'Riordan from the Cranberries, and Tom Petty. So quite a few of them had other drugs in there as well, but fentanyl would have been the most dangerous one. So what's been happening, Dr. Frey describes as the perfect storm, where there's strong marketing for it. We've also got an ageing population with lots of issues with pain. People want an easy fix. It's far more likely people want the passive treatment for their pain rather than an active treatment. It's much easier just to take a tablet than to do other things. GPs have pressure on them to keep their business going, to have the high turnover of customers. And there's also stigma about coming to an AOD service that a lot of people put off by. So people wanting to, I've seen many clients over the years where it's a real hard step to take to access an AOD service if all their medication they've got has been prescribed for them. They see our services as being for people with drug problems, not for them. Pharmacists are there in a good position to be able to address the issue. So looking at what's happening with dispensing and being able to monitor potential misuse, able to provide education. But what we've got is that there's Queensland pharmacies, there's 1,166, and only 581 of them actually involved with the opiate treatment program. It's about half are involved with the treatment. So the other half are willing to hand out the opioids that cause the problems, but not hand out the ones that cause for the treatment. So Susan Nielsen talked about how they're in the front line, but they don't really have the training to be able to deal with it. So it's something that probably could be addressed, where they're going to be seeing this happening if they have some training to be able to identify those who have issues and then make some good referrals. Nudge. The nudge theory, the idea of a little thing can sometimes change behaviour. And so the Federal Health Department sent out letters to the 20% of GPs at the highest rate of opioid prescriptions, and this had been effective in the US and UK. So for many people, getting a letter from the government about what you're doing is at a bit out of sorts with the rest of your profession would make an impact. But there are some who are over the top and being described as local pill mills. So one country doctor was identified was prescribing 68,000 doses of opioids in less than a year, and a city one of 56,000. So I tried to do a little bit of maths and took out the weekends and took out the public holidays and took out 4 weeks holiday, and I came to a figure of 300 a day. And I still couldn't see, how is that possible? How do you do that? And this has serious impacts. So Angus McGivern died from an opioid overdose, and so he had been prescribed multiple fentanyl patches from different doctors, and his mum Sandy would get the medication packets, the empty ones, see where they came from and ring those places to ask them not to prescribe. And so I think they might have been getting letters as well as her phone calls, but he still got the prescriptions. The POINT study being done by NDARC, so it's a long-term study following 1,500 people who've been prescribed pharmaceutical opioids, and due to finish next year. And so far what's been reported is that 15% are on daily doses of more than 200 milligrams. So MRQ guidelines say do not exceed 120 milligrams. So there's a large proportion doing that. And what I thought was interesting was that those taking the higher doses are reporting less pain relief. So, what's going on if it's not the pain relief? So most of the people had multiple pain conditions, poor physical health, but also some other factors too. The child abuse and neglect. A large proportion having issues with depression, and also other substantial groups also having other mental health issues too. What the POINT study has found is that doctor shopping is rarely reported. but they're finding that early prescription renewal is quite common, and asking the doctor for a dose increase is quite common too. This is something that really stood out too, is that the people who are being prescribed, it's often the ones who are at the greatest risk. So the people who get the increases in their doses are the ones who have the highest number of risk factors for having problems with opioids. So instead of what you'd hope would be the other way around, that if people are more likely to abuse it, that they'd be less likely to get prescribed, the data didn't stack up that way. So there's a big connection with mental health going on. So looking at those who are using pharmaceuticals for non-medical use, a much larger proportion than what's in the general population have mental illness, and also higher levels of psychological distress. So this keeps coming up again and again, that there's mental health issues involved with the prescribing of opioids. So people who abuse their medications tend to have high pain sensitivity, but also the way they interpret the pain. They're more likely to see it as being something more serious than what it actually is. More likely to have other psychiatric symptoms and a history of substance use disorders. So the idea of treating pain now is nearly every international guideline is recommending being active, not bed rest. And so it's a common thing that with opioids that people become more sedentary, that it actually makes it harder to be more active. And so there's muscle tone that might be helpful is actually starts to get lost rather than being increased. Pain and opioids. So what we've seen is that the evidence for benefits less than what we expected, and the evidence of harm is greater than expected. So the evidence is pointing towards not prescribing opioids for chronic pain. Those who are getting medication only as the treatment, well, often there's quite unrealistic expectations about what the medication is going to provide, and there seems to be an underutilisation of other treatment options there for besides the medication. I don't know if you can read, it might be a bit blurry, but the patient's telling the doctor, I think the dosage needs adjusting. I'm not nearly as happy as the people in the ads. Professor Nicholas from the Royal North Shore Hospital has spoken about how the drugs don't actually help with the cause of the pain, and they also can limit you too, dull you as well. And so people need to accept that a certain amount of pain is inevitable and just finding ways of living with that and working through that. So I think there's an unrealistic expectation that pain can just be eliminated entirely. Paul Grinzy is a GP from Victoria and chair of their Drug and Alcohol Committee. And he's spoken about this as well, that to manage pain, that it takes time. It's not something you can do in one visit. So he discourages people who come into his practice just seeking to pick up a script like they're going to a supermarket to buy a product. Exercise physiologists. Everyone heard of them before? Yep. Yeah. So I think they're underutilised. So people can access them through the Medicare benefits schedule, and I think it's quite affordable if you look at the costs there. And they'll help with exercise that can relate to whatever the pain condition is and improve the quality of people's lives. Psychologists, heard of them before? Yeah, okay. They could have the uses. So I think there's a big overlap with so many people getting opioids to actually deal with mental distress. And so there's a big overlap with depression. And there's, especially if you look at people getting to the point of going to a pain clinic, about half people there meet the criteria for depression as well. So pain, there's a whole lot more going on than just the sensory dimension. So there's other dimensions to pain, and it's worthwhile being aware of that. So the effective one there with what's happening with emotions, and also other things like cultural dimensions to pain. So I heard a midwife talk about her work, and she worked in the Torres Strait Islands, and she said the only way you could tell when the women were about to give birth was little beads of sweat would appear on their top lip. There was just that cultural difference about expressing pain. Whereas if you're working with other groups, they might be telling you a bit sooner. The opioid substitution program, a little packet of Suboxone there with the bluebird of happiness just flying away. So this is an interesting study that found that people who are on the opioid substitution program who were then using other opioids on top of what was being prescribed, that didn't relate to having pain. So that extra use of opioids wasn't in response to dealing with pain. Drug-induced deaths in Australia. So prescription drugs actually cause the highest number of deaths if you take out tobacco and alcohol. But when people are asked about that, which is responsible, only 1.9% of Australians were aware of it. So people don't appreciate just how dangerous it is, which I think also explains why I was talking about earlier how there's quite a high approval rate of misuse of pharmaceutical medications. Most people don't appreciate just how dangerous it can be. So we've seen that so many people have mental health conditions who have died from opioids. Many living with chronic health conditions like Hep C. I'm going fast because I put a lot in here. This is interesting, looking back to 1999 with time of heroin, and so often people talk about opioid deaths being increasing, or so many back in that period because of heroin, but which drug was ranked number one wasn't heroin. Heroin came in at number 3, while these other opioids were actually number 1 back then in 99 even. So it's often spoken of as heroin was the main one there back then. Whereas now it's benzos is the most common drug, and then other opioids including oxycodone coming at number 2. And you can see I've got a little red arrow there showing the big increase with fentanyl. So from 99, 68 deaths up to 2016, 234 deaths. So with the death rates, you can see opioids coming out way on top, above others there. The depressants, the benzos and barbs, kind of echoing or mirroring the same patterns below. But opioids is well and truly the top one there. A burden of disease study that was done in Australia, it just released this year. And with the burden due to illicit drug use, opioids was the greatest one there, with 41%. So followed by amphetamine use with only 18%. So quite significantly, the top factor in burden of disease. The coroner's court. So there was a coroner's inquest and death from opioids released this year, and due to concerns about what was happening with oxycodone and fentanyl. In that, they looked at what MRQ were having to deal with, just the number of prescriptions that were being processed, and so it's an enormous amount that they were having to try to monitor. So the Health Ombudsman noted that there's insufficient time to be able to do all this work, and that recommending real-time prescription monitoring as a way of being able to manage it better. There's also concern about the high volume of letters sent, but without the follow-up for those who don't just respond to a letter. The number of investigations that MRQ were able to do was quite limited. So at the time they only had one investigator, and so it was very few prescribers who would be investigated, and so obviously there's a need to increase that too. So looking at that monthly average, I mentioned about that before, about how it's greatly increased, and the types of conditions people are being prescribed opioids for, like low back pain, neck pain, migraines, are very, very common ones too. So that's what's happening and what can be done. So last little bit of time, I'm just going to talk about some of the things that might be helpful. So the coroner recommended looking at what's happening with prescribing and talk about doctor shopping, which I think the research shows it isn't such a big issue. Providing more education, so it's something that we've been talking about with work done here at Insight. The introduction of the real-time prescription monitoring system. GP education. So at the moment there's no sanctioned education programs, it's voluntary ones that people do. They're available online if they choose to do that. This is an interesting study done in the US that with treatment, people who are on opioid substitution for prescription opioids do quite well. So it appears to have better outcomes than people from other illicit opioids. Real-time monitoring of prescriptions. So AMA spokesman Dr. Kidd recognised the urgent need for this because any delay means more people are dying. And Pharmacy Guild President Chris Owen also said the same thing, similar things, that it could be the only proactive tool in stopping doctor shopping. So the Federal Health Minister has put funding towards this, so recognising that real-time prescription monitoring is a priority. I'm not sure who's in the distance over there. It might be Malcolm Turnbull escaping. So they announced they're going to spend $16 million with that rollout, which Victoria are starting, and in Queensland looking at next 2-3 years in implementing it. Tasmania did it first in 2007, and they did have the highest consumption of opioids and benzos at the time, and there was no ceiling dose for opioids, and so introduced the real-time prescription monitoring, which was called DORA, hence my little picture of Dora the Explorer there, and they have seen benefits already with the overdose rate coming right down. Victoria has Safe Script, which is starting very soon, or may have been trialling it now already. And so it makes sense. You look at the death rate from drug overdoses is higher from prescription opioids compared to illicit opioids, and also higher than the road toll in Victoria. Dr. Khan's in the US, and he spoke about this as a public health crisis, and that no other prescribed medication comes close to the suffering caused by opioids. And most people whose lives have been destroyed by opioids were not seeking out opioids to get high. They were first exposed through a legitimate prescription for chronic pain. Dr. Art Van Zee, he's a bit of a hero from what's happened in the US. He's a country GP who just saw his patients dying. He lived in a country town, so these patients were people he knew or relatives of friends of his, so it had a big impact. So he campaigned very hard. Often he'd be testifying where Purdue were paying umpteen other doctors to testify against him. And he's spoken about some of the changes he'd like to see. And at the moment, what they had in the US, they have these sales reps getting these big incentives, and that just seems to increase prescribing rather than the evidence. That also, the idea that the FDA would actually review the advertising material before it went out to see if it was truthful, rather than having all this false information going out there. They would actually need to increase the FDA's support and funding to do so, and taking the pharmaceutical industry out of the medical education system, which makes a lot of sense too. The TGA in Australia had a consultation paper with a number of recommendations: real-time prescription monitoring, labelling, it's actually good warning labels on products, more access to opioid dependence. Another one I liked was just the package sizes. Rather than giving people a packet that's big enough to get a problem with, just smaller packaging, so they just have a few days' doses if that's what's needed. Review of the indication for strong opioids. Actually consider whether that should just be prescribed by specialists. Looking at other plans for managing it, raising awareness about the risks and dangers for opioids. So a number of good ideas there. And the Federal Health Minister, Greg Hunt, has recently announced more funding for Pain Australia to develop a national action plan to address chronic pain. I finished in time. So I packed a lot in, so I rushed. So I'm sorry for people who are trying to read every word on the slides, but there was so much to cover, and it's such a huge story, it was hard to compress it into 1 hour.
Any questions? You've answered everything. Any questions online? One question. Are there any other studies on Aboriginal and Torres Strait Islander opioid use or rural and remote areas compared to more city-based?
Yeah, not that I'm aware of.
Hang on, Jeremy, want to answer this question?
No.
Okay. No, not that we're aware of, sorry.
There may not be an answer. This coding was rescheduled in February. Any data on improved outcomes, the results being achieved?
Yeah, no, I'm not aware of, yeah.
Absolutely. Thank you. Any other questions? Alrighty. Thank you, Dan. I just wanted to let people know before they leave, we're pleased to announce that we're launching a new toolkit today on the Insight website. It's called Opioid Check. So if you go onto our website and click on toolkits, it's there. We've got a brand new opioid e-learning package that you can scroll through. It'll take about probably half an hour, and it's all the basic kind of information around opioid, the background history, rates of use, harm reduction, responding to overdose and treatment. And Louise, who was here a second ago, she's just been working with the DABIT and the CL kind of staff across the state and has developed a series of withdrawal management quick reference guides. This is the first one which has been finalised, and we're releasing more in a couple of weeks' time, but it's a quick reference guide around opioid withdrawal management, and maybe Dan's going to hand out some copies so you can have them. So they're just useful, particularly if you just need a summary of the evidence that's based in the 2012 clinical withdrawal guidelines. It is just based on those, so there might be additional evidence that medical addiction specialists can add to it, but it's just a quick reference to some of the key points from that guide. And also we've got our first of a series of new check tools, similar to Meth Check. This one is Opioid Check. I'd like to acknowledge the work of Kira Willis, who's here today, in helping develop this tool and other tools. So this is an ultra-brief intervention resource that can be used for an initial conversation or in a GP setting, which just does a quick kind of a quick assessment or screen, just a conversation prompts, a quick decisional balance, calculator, and then on the back some harm reduction tips and some tips for cutting back or quitting. So again, useful for workers who just want to have a conversation and need a bit of a tool to assist them to do it. And then we've got a whole bunch of videos and resources and recordings, particularly Dr. Jeremy Hale. I'd like to acknowledge all of his time in producing some video content that you can watch at your leisure. So if you want to look at those resources, please feel free to check them out, download the ones that are useful and share them with your colleagues. So thank you for joining us today. Thank you, Dan, for that very in-depth kind of investigation into the world of opioid use. And please join us next week for the Great Vape Debate with Associate Professor Coral Gardner. And please fill out an evaluation. Have a great day, and we'll see you next week. Thank you.